change lives by relieving suffering or saving lives. We mentor young people as they're preparing to become our colleagues, and we do research and innovation that makes healthcare better. In fact, this room is full of people who I've looked up to doing the research on burnout that's helped guide our work. Healthcare gives us the opportunity for a broad array of pursuits for professional fulfillment, and yet, over 2/3 of us are burned out. People looking at it from outside of healthcare wonder what's going on. But if you follow us into the hospital or into the clinic, you see that we spend 2/3 of our time not on this professionally fulfilling activity, but on administrivia, like typing data into the electronic medical record, fighting with insurance companies for prior authorizations, wending our way through dysfunctional workflows, or trying to help patients understand that the misinformation that they've come to believe is actually dangerous to them and hurting them. Now, we look at burnout and we realize when we're working in this milieu, the problem with burnout is not a lack of individual resilience. We are some of the most resilient people in the world, and researchers in this room have done the work to demonstrate that as well. The problem with burnout is the workplace. WHO says as much. It defines burnout as an occupational phenomenon. It has 3 main manifestations. We're exhausted. We've given everything we've got. We're completely depleted. When you get to that point, you start to protect yourself. You protect yourself from your patients. You protect yourself from your organization. That shows up as cynicism. And when we're sitting with a patient, in that encounter, that patient may be finding great value. At the very same time, we're wondering if we're making any difference at all. Now, Christina Maslach created the Maslach Burnout Inventory that helps identify all of these and gets the relative weighting for each person's individual experience as well as experiences across the organization. She also identified 6 key drivers of burnout that lead to these manifestations. That first driver, work overload, no surprise to anybody here. And that overload in working in these chaotic, time-pressured environments, that drives the exhaustion. And when we realize this, we also realize we have tremendous opportunity to address this major issue in burnout. Because we can redesign the way we do our work to actually open the opportunity for work-life balance, to open the opportunity so that when we are at work, we can focus on our patients. Most people think this is burnout. This is all there is to it. I'm overloaded and I'm exhausted and I need to fix that. And there's a lot of truth to this, but it's not all there is. Maslach identified 5 other drivers of burnout. The first is lack of control. When we're overloaded, we lose control. Control is a big deal to us as physicians. We dedicate the decade of our 20s while our friends are out having fun or getting their families started or building their careers to simply getting the training and knowledge we need so we can take control when our patients need us to do so. Control is one of those intangible rewards we look for when we enter the profession. And in fact, insufficient rewards is the 3rd driver of burnout. It's not just control, there's professional recognition, there's gratitude for the great work that we do. And there's collegiality. You know, doctors and nurses we're pretty fun people to hang out with when you have a chance to just hang with us and get to know us. But we've seen breakdown of community because we aren't that connected anymore. Whether we're working in a strictly outpatient or inpatient environment, or whether we're together in a room, but we're focused on our technology rather than our colleagues that may be sitting right next to us. The next driver, absence of fairness. Are you treated fairly? Is there favoritism within the team that you work in so that not everyone is really being treated with a level playing field? Or Have you experienced discrimination, not because of the quality of the work you do, but because of something you have no personal control over? Your gender, your race, your country of origin, your sexual orientation. Now, this one's a tough one for me to talk about. I'm an old straight white guy, okay? I haven't experienced the same levels of challenge that now the majority of our workforce experience often on a daily basis. And lastly, conflicting values. Does my organization share my personal values? Or have I been forced, particularly during the pandemic, to observe or even participate in activities that really violate my personal values? The thing about these other 5 drivers of burnout, they don't have to do with the workflow. They have to do with how you lead. Whether you lead a team as small as 2 or 3 people, or a team as large as 20 or 30,000 or more employees across a health system, how you lead determines whether this leads to cynicism when we lead in a way that doesn't honor these important values for physicians, or whether you can lead with empowerment and alignment and drive great engagement. Another way to think about these drivers is to compare them to Maslow's hierarchy of needs. Remember back in Psych or Sociology 101, the way that we were motivated to improve and we had to meet each basic need and take one step up the ladder? Well, when we look at Maslow's drivers of burnouts, we realize work overload has a big impact on our physiologic needs. I'm going to stop for a second. This is the first point in the presentation where I'm going to ask for audience participation. Is everybody ready? I would like you to raise your hand high and keep it up if you have ever denied hunger pains and skipped a meal because there was too much work to do and your patients just needed you immediately. Now keep your hands up, because if you keep them up, if you've ever denied the fatigue you were experiencing and did not sleep because there was too much work to do and your patients needed you immediately. And one last thing, have you ever denied the signals coming from your bladder and held your pee because there was too much work to do and your patients needed you too soon? We've all been there. Moving up, lack of control has a direct impact on safety. Breakdown of community has an impact on love and belonging. Rewards and fairness have an impact on esteem, and values conflicts impact self-actualization. We can equate self-actualization with professional fulfillment. There's also been great work that's come out of the discipline of human factors engineering, demonstrating the impact of burnout on our brains with cognitive overload. We see elevated cortisol levels reducing cerebrovascular blood flow. We see glutamate levels increasing, limiting our fine motor control. And we see thinning of the prefrontal cortex, enlargement of the amygdala, and shrinking of the hippocampus, impacting our short-term memory, our decision-making, and our ability to moderate our reaction to stress. For those of you like myself who are old enough to remember the Reagan presidency years when Nancy Reagan had her "Just Say No, Let's Not Do Drugs" campaigns going, there was a commercial that showed a frying pan and an egg, and they cracked the egg into the frying pan and said, "This is your brain, the egg. This is your brain on drugs in the frying pan." So, this is your brain on burnout. How did burnout happen? Remember, the problem isn't the clinicians. We are amazingly resilient. The problem is the workplace. And how did that workplace get to be such a challenge? Over the last 20 years, there have been multiple external factors that have impacted the workplace. Let's take a look at a few of them. First off, the EHR, the bane of many of our existence, that brought with it, as it got deployed by the government, things like meaningless abuse, meaningful use in how we deploy the EHR. It got augmented by things like ICD-10 or the E&M coding changes, which made it that much more challenging for us to work. But the payers loved it because they could use mistakes we made to deny payment or to demand greater prior authorizations. The government got in the act, and justifiably, they're trying to make things better for the entire country. But some of those things had unintended consequences. We're looking for quality and use patient satisfaction, HCAHPS, CGCAHPS, as an assessment of whether we're providing quality work, quality care. And I don't know about you, but if you've ever had the pleasure of talking to your colleagues about their patient satisfaction scores, they might have said something to you like, oh yeah, sure, fine. That's not really the way I am. And besides, the patients are getting sicker. They're getting older. They're more culturally and linguistically diverse. And you know what? Even the ones that are culturally coherent with me, they've consulted Dr. Google first. They don't come to me asking for my professional opinion, helping to diagnose what's wrong with them and giving them the treatment that they need. They come telling me what they want me to do for them. Oftentimes it's giving them opioids because it used to be the fifth vital sign, and we wanted to treat pain, and we had no holds barred, and we realized that created the opioid crisis. So now we deny opioids, and people get mad, and they come back and wreak violence on our workplaces. And we've seen such growing issues with violence. So maybe we should just get rid of patient satisfaction scores. After all, that would take care of a lot of this, right? And we hold that applause. And take out your phone and open up your Yelp app. And I strongly encourage you to just Yelp yourself right now and see if you aren't being rated in a way that the government has no control over. As health systems have been working in these challenging situations, fighting with insurance companies, they've thought, let's get bigger. Let's get more ability to negotiate more effectively with mergers and acquisitions. Is there anybody in the room who works in an organization that hasn't been through a merger or acquisition? Anybody? Bueller? One or two. Good. What happens with mergers and acquisitions, it creates great internal distress in the organization because we think organizations coming together, we're all in healthcare, we all have the same noble intent. Gosh, we should be pretty much similar, but we all have different cultures. So we deal with these culture dysfunctions, and it distracts senior leadership from attention to the issues on the front lines while they're trying to work out these other major issues that include financial and legal obligations. Thank goodness we have our professional associations here to help us with maintenance of certification to demonstrate to everyone else just how qualified we are. Oh, we only have to spend a few $1,000s and a few hundred hours preparing for it, but what the heck, it really makes a difference. And ultimately, we're getting paid less for everything we do. Now, we could go around the room, and I would bet almost every single person could add one more unique thing to this circle. And somehow, in the last 20 years, we've adapted to it, even pre-pandemic. We just absorbed it. As long as we could still connect to those things that gave us professional fulfillment, we figured out the EHR. We dealt with patient satisfaction. We confronted Dr. Google. But we've gotten to the point where each one of those things is like a little straw being added to the camel's back. And we cannot take any more. And pre-pandemic, people were breaking. We saw injury, substance abuse, family dysfunction, suicide. This impact on health systems pre-pandemic was already causing problems with reduced finances, where we started to get paid less for each unit of service we provided, and in order to just maintain sanity, people cut back on their workload. This combination of doing less work, getting paid less for it, isn't going to solve any healthcare system's margin, and without that margin, we don't have the money to do all the other things that we're trying to do here. So administrators are burning out as well. Not as bad as physicians and nurses, but they are. And of course, then things got worse. Along came our little friend that turned into our big problem, and we were thrown into this middle of this VUCA environment. VUCA is a term from the military. It's an acronym for volatility, or rapidly changing environment. Uncertainty, there was no clarity. complexity, there were so many variables, and ambiguity, there's no precedent existed for what we experienced. And as we all know, this has led to the Great Resignation. This article actually came out in the Washington Post over a year ago, but it's only gotten worse. We are now experiencing an existential threat to our healthcare systems, which has to lead us to ask this question. Is this really sustainable? I mean, just look at some of the quotes that have come out just in the last month or so. This is the biggest increase in emotional exhaustion that we've ever seen anywhere, the article that Dr. Resnick quoted earlier. In-basket messages are up 157%. There's actually a blog post in Kevin MD even just this week by a primary care doctor in the University of Michigan system, Paul Fine. And he has identified a new syndrome called portal hypertension. See, I don't even have to explain it to you guys. And health systems are on the verge of collapsing. 23 laid off patients simply so they could keep the lights on. We're facing an incredible crisis, and it's going to take a combined effort focused on two things. We almost don't need the quadruple aim anymore. We need a double duple aim. We need to beat burnout and build the bottom line concurrently, because we can't do one without the other. Now, just 10 days ago, National Academy of Medicine came out with a culmination of their 5 or 6 years of work on this with their national plan. And it's important, it's got great stuff. Create and sustain positive work and learning environments and culture. Invest in measurement, assessment, strategies. Support mental health and reduce stigma. Address and sustain and compliance and regulatory policy barriers. Engage effective technology. Institutionalize well-being as a value. And recruit and retain a diverse and inclusive workforce. These are all vitally important, and in fact, many of the people in this room were intimately involved in developing these recommendations. We need to pursue them. And we have a great way to pursue them that's been around actually for many years now, which is the Stanford WellMD model to pursue professional fulfillment with 3 main areas of focus. The first is on personal resilience. And we do this really focused on by creating efforts within our organizations to support our clinicians. For me, one of the more challenging guidelines that's really important as a basic value in this is the concept that self-care is not selfish. We're resilient people, but we're also very altruistic people. And many of us grew up in some religion that had an element of guilt to it, that we would feel like, we see our patients, they're suffering, we wonder, shouldn't we suffer equally with our patients? But if we don't take care of each other, if we don't get past this idea that self-care is vital, we are not going to be self-sustaining. I've been asked to put a plug in for one of the breakout sessions. Now, I love this session. This is going to be on from all in well-being in healthcare. You can see it's sponsored and being presented by 2 key people in the room. First is Gary Price, president of the Physicians Foundation, which has been a driving force between this conference and All In. And Corey Feist. For those of you who don't know Corey, Corey and his wife Jennifer lost Jennifer's sister, Lorna Breen, to suicide early in the pandemic. And they amazingly took this deep heartache and turned it into a movement to make sure that they do everything they can to be sure that no other family, no other clinician ever has to go through this again. So they're presenting today at 10:30. And I say this with trepidation because there's 4 other great breakout sessions going on at 4:30. One of them's being done by Christine Olson, who you saw on the screen up here. Another's being done by Lottie Derby, a chief wellness officer that came out of Mayo with the the, the four horsemen of burnout, I like to think of them: Steve Swenson, Tate Shanafelt, Colin West, and Lottie. And there's two others that are great as well, that are going to be focusing on interventions, on measurement, and on solutions to burnout. So there's no one best one to go to, but Corey deserves some special recognition, so there you go, man. Next is efficiency of practice. We've talked about that already today as well, right? We need to create systems where we actually can reduce exhaustion and regain work-life balance. The ways to pursue that include redesigning workflows, really intentionally, formally investing in redesign, optimizing the EHR, and using huddles on a daily basis. When I think about workflow redesign, I think about this as an opportunity to flip the ratio. Now, you may say, flip the ratio? What ratio are you talking about? I haven't heard about that as much before. Well, remember, we talked about how we spend 1/3 of our time on meaningful activity. 2/3 of our time we're spending on waste, on administrivia. Imagine the potential if we flip that ratio. If we spent 2/3 of our time on meaningful activity and we did 1/3 of our time in administrivia that was needed to support that 2/3 valuable time, what would that mean? What would that mean for our work-life balance and our ability to focus on our patients? What would it mean to improve quality, safety, patient experience, access, and productivity to fund all of our work? To have the capacity to focus on well-being for the workforce. We need organizations focused on this work and investing in it deeply. There's a whole array of opportunities to fix the workflows. EHR optimization, fixing the in-basket, redesigning each workflow, inpatient or outpatient, and redesigning our facilities to enable this work. So here's the second audience participation segment of our work, and this is the audience polls. This first question is just to help everybody get familiar. We're going to take a minute to get familiar with the app and how to do this. So take out your phone, open it up. Hopefully I'll open here. And when you open the event, you'll see as you go through it, you can get to where this talk is listed. And folks in the back, correct me if I say something wrong here. If you click on this presentation, you should come up with a thing that says audience polling on it. And we should, I'm told, we'll see, be able to actually see the polling come up on the screen as we do this. This first question is really going to be just finding out who's in the room. What's your job? Are you CEO, CMO, Chief Wellness Officer? Are you guys finding the polls? Is it coming up for you? Yep, great. Is there a way we can see them up on the screen up here? Because I'm not seeing it yet. Any help there? Yeah. Oh, it's just on my phone? Okay. I will get out of airplane mode because I didn't want to interfere with the AV. And let's see. Okay. Opportunity, take the poll. Okay, so I can take the poll, but I don't know if I submit my response. Oh, here we go. Yeah, I'm seeing the responses. I don't know if you are. Can you see them on your phones? You should, I think. Yeah, great, good. Well, there you go. So 2% of the people in the room here are CEOs. That is awesome. It's so rare to see the CEO this deeply engaged. 5% are CMOs, 20% basically are chief wellness officers. I'm a little concerned that there's no support service people here, CFO, or very few, CFO, CHRO, COO. No, there's nobody from tech, no CMIOs or CIOs in the room. Okay, guys, this is one thing we're gonna have to do when we go back home. Your first job is to go make an appointment and meet with your chief medical information officer or your chief information officer. We need their engagement. I love the fact we've got department chairs, we've got division leads, and I'm glad that there's 45% of people here say they have no administrative role. Other than the vendors, I'm hoping that those are people who are, like I was early in my career. I didn't have an administrative job. I just was trying to take care of patients and dealing with it and trying to figure out how to do that most effectively. Awesome. Now, how do we get to the next question? Let's see. Can we get to that next question easily? I'm not seeing how to get there. So, oh, here we go. So if you go back in and out, there's a question about passwords. Now, this question is, do you type in your passwords, or do you have a single sign-on tap and go by which you do your passwords? And I'll tell you a little story. As I was checking in yesterday, I ran into a good friend, Chief Wellness Officer at University of Missouri, Steve Kaitan. He'd heard me ask this question once in front of a room before and realized that actually you don't have to type in your passwords, and there are places that do single sign-on. And he went back and talked to his leadership, and they actually were able to get that implemented. Here's a great example of how these conferences actually can lead to change. So how are we doing on this one? 61% of people are typing in passwords. 61%. This I think of as a litmus test for whether an organization is truly committed to reducing burnout. What's your guess the average number of clicks you do a day just putting passwords into the electronic medical record? It averages probably around 800 to 1,000. These passwords have to be anywhere between 8 and 14 characters long. You've got to have caps, small letters, numbers, some punctuation type marks, but certain ones you can, certain ones you can't. Changing them every 3 months, trying to get all that on base. Maybe your different systems don't even have the same password. It drives you crazy. And it takes an investment, but it makes a world of difference when you're not distracted away from your thoughts about how you're caring for a patient by trying to get that password in. The next question, oh no, that was the role and title. So I guess we come back out and come back into the next question, take the poll. And there we go. So the next one, have you participated in a formal redesign process for your workflow? Yes or no? We submit the response, and so, well, actually, this is pretty encouraging. 48% of the people in the room have actually participated in formal workflow redesign. I was expecting lower. It's good to see. It also means 52% of people haven't. There's all that much more opportunity for us to make a difference. But we're on the road there. Actually, is it more people have participated in a workflow redesign than have single sign-on for their passwords? That's pretty cool. This is working out better than I expected. Let's see, the next, we have one more question, all right? 2 more. Gotta get to the next one. Here we go. Do you work in a team care environment where you have more than one person who supports you directly? You know, we're high-powered professionals with a lot of education. I was talking to a gastroenterology friend of mine. He said the day he started his first job as a gastroenterologist, the day before he had just graduated 26th grade. I mean, we get so much education, we get so much knowledge, and we're treated often as a frontline secretary. Nothing against secretaries, administrative assistants help us survive. But we shouldn't be doing administrative assistant level work, and we too often are. So let's see what the answer is here. Wow, this is impressive. 61% of people are working in an environment where you actually have more than one person directly supporting you. That is also really encouraging. Still a ways to go, or 59%, but still, that's great. And then lastly, let's ask the S question, the scribes. And take Takes a minute to come up. Here we go. Do you use an in-person scribe, a virtual scribe, or no scribe at all? I don't know about you, I'm a little surprised at this. I'm seeing 4% use an in-person scribe, 6% use a virtual scribe, and essentially 90% of people don't use any scribe at all. Now, it might be that you're just really great. A lot of people are very good. They've figured out their EHR, but I imagine that's really not the majority of people that are not using a scribe, that are still, despite the way that technology has improved, we're still tethered to just typing everything in order to get our work done, our notes documented. Here's where we have so much opportunity. So thank you all. You did a great job of participating in this audience participation segment of today's presentation. And let's move on, because we'll talk a little more about this workflow redesign. You've probably seen a chart like this. It's a value stream map, a workflow analysis, identifying every step in a process from start to finish, figuring out which of those steps actually bring value, which of those steps are total waste or make things worse, and identifying ways to redesign it so we can get rid of the waste and maximize the good. And we do that. It's really important when this work gets done that it's not done by some outside expert who comes in and says, oh, I have the answer. We have the best practice from St. Elsewhere, and we're going to help you put that specific best practice into place. Because what works in one place may work somewhat well in another place, but doesn't always. It's so specific to our own work. And we need the people who do the work to redesign this work, particularly if we're going to do it in a way that's truly innovative, that's truly changing the design. So it's vital that we have physicians engaged in these teams. And when we started this work in places I've been, I would come to you and say, Dr. Jones, I would really love for you to spend 4 days with our team, not taking care of your patients, but on this team where we're going to redesign how your patient moves from the waiting room into the exam room all prepared for you. Can you spend 4 days with us? And you'd probably look at me and say, dude, you're cray-cray. There's no way I can be gone for 4 days. My patients need me. My colleagues need me. I can't be gone. So I'd ask you, do you ever take a vacation? Because you need to refresh and replenish yourself. But when you're gone on vacation, hopefully you're not there for your colleagues, you're not there for your patients. Or do you ever go to a CME course because you want to stay current, you want to be a good doctor, you want to make sure your patients are getting the best and latest care, but when you're at that CME course, you're not there for your patients, you're not there for your colleagues. And then you come back from that time away, and within a half an hour or a half a day, all of that refreshment and replenishment is gone because you've dove back into this chaos that overwhelms you. And you try to implement your new knowledge. And it is hard because things are so unorganized, you can't figure out where to start. The most important time that you spend away from your practice is the time you invest in improving your practice. There's another time we ask people to step away from their practice, not 4 days, just 15 minutes, using a huddle to address the drivers of burnout. And I know you're under this amazing pressure to produce. And a 15-minute slot is one more patient you can't see, one more bank of RVUs that you can't put on the books. And people will say, there's no way, I'm confused. You're telling me I need to go to a huddle, you're telling me I need to be productive. This doesn't work. In fact, teams that spend that 15 minutes together on a huddle are more productive than teams that don't huddle, or teams that only huddle but the physicians aren't there to be engaged in the process. 15 minutes is all we ask. During that 15 minutes, key things happen that really reduce burnout. First of all, we acknowledge, appreciate, thank someone who did something great to make our day better the day before. Remember that driver of burnout, insufficient rewards. We prepare for the day. Do we have the capacity today to meet the demand that's coming at us? What is the census or the schedule compared to our staffing, our equipment, our supplies? Quite often, we may not have the capacity today to meet the demand coming at us, but we can start the day with contingency plans. So we're ready to deal with it when those problems happen in the middle of the day, rather than being shocked, surprised, and thrown off course because it happens to us in the middle of the day. We measure metrics. Everybody's favorite. Let's all measure metrics. But it is key. We know our systems have performance expectations that are key to them actually getting the reimbursement they need, to building the reputation, to bringing patients in. And those metrics don't magically appear on a system scorecard that some CFO generates for us. They are developed by the work that's happening in our offices, in our units. And those metrics that we focus on in the units are simple things. Did we fill every slot in a schedule? Did we greet every patient properly? All those kind of small things that drive those system metrics. We can track those easily at the front lines, and we can use that to then improve. And when we're off track on those metrics, we problem solve. So we problem solve on the metrics. There's another problem solving aspect as well, though. How many times has it happened where you're half hour behind already in your schedule, you go to open up a drawer to get something you need, and it's not there? And it's like, I gotta go out, go find that thing. Hopefully won't get waylaid in the hallway with something else to do. Find it, go ahead, get back to work. Or I've just printed up or ordered the after visit summary for my patient, and I go out to the room to the printer to get that paper to hand it back to the patient, and the printer's out of paper. These little things that can drive you crazy in the middle of the day. And you swear you'll never let that happen again. And by the end of the day, you're so exhausted you forgot about it till it happens again the next week, and then you're even more frustrated. If we take that moment when that happens, if we have a huddle in place where we do problem solving, we realize that's an opportunity to improve. We take a note, an opportunity card, and put it on the huddle board. The next morning, we go to the huddle. The team discusses whether this is an opportunity that we're going to collectively work on or not, and gradually solve that little problem. Those little pebbles in your shoe that just wear you down. Too often, those pebbles, there's many, many pebbles in the shoe to start with. It takes some time to really get those pebbles out of there enough that we're moving more comfortably again. But if we don't get started, we don't get there. Organizations, sites that do these huddles, we've seen tremendous value and improvement in something that's a relatively small investment. We've seen places where they were hemorrhaging support staff. The support staff turnover rates were 60, 70% in the first year. And with implementing huddles and the work that went into it, the team coming together, building a different sense, internal culture, people coming to the manager of that site and saying, you know what, I was ready to take another job next week, but since you guys started this is good. I want to be here because I feel like I'm working with people on a team together, and I don't want to lose that. And lastly, and while the great opportunity is in fixing workflows and recapturing that ability to connect to patients and to get time for ourselves, this can't happen without leadership, without focusing on our culture of wellness, where we reduce cynicism, empower clinicians, and align everyone. And there's a number of activities we can do that help us do that. The most important thing right now is that it is time to transform leader-clinician relationships. These are so broken. There is more antipathy than connection in most organizations I see. We see unionization of physicians. And frankly, I think of unionization as a failure of management. If people feel they need to find someone else to represent them, to take care of them, to focus on their needs because their leaders aren't doing it, that's a failure of leadership. Now we have great opportunity here and great guidance. Dr. Tate Shanafelt, we were both presenting at a conference in July. the Coalition for Physician Wellbeing put on by Dr. Ted Hamilton. I don't know if Ted's here or not, I haven't seen, but he introduced Tate as the George Washington of physician burnout, which I thought was awesome because he really has been the most inspiring leader we've had. But this concept of wellness-centered leadership, based initially in caring about people always, as the foundation for how we go forward, and using that to then cultivate relationships with individuals and teams, and from those relationships, being able to inspire change is what it's all about. Particularly because we are unique. We are knowledge workers. Peter Drucker, famous management consultant, defined knowledge workers as people who need to think for a living. We innovate. We're problem solvers. We innovate constantly. When you stop and think about it, every single patient we take care of, we need to innovate a little way to use our knowledge to meet them where they are so we can be most effective in improving their care. We know more than our manager does about the work that we do. When I was CEO of a large medical group, I'm a family physician. I didn't know more about neurosurgery than the neurosurgeon did. I could support the neurosurgeon, but I couldn't tell the neurosurgeon what to do. That autonomy is a necessity. Certainly in my practice, I wanted the autonomy to fix things that weren't right. In fact, I got into management because I couldn't keep my mouth shut when things were bad. And I spoke up, and I got put on committees and chaired committees and moved on up that management ladder that many of you are probably experiencing. But when I became CEO of a large medical group, the thought of 300 physicians, each independently, autonomously solving problems the way they thought they needed to solve those problems, scared me to think that we would fall apart from entropy as everyone was doing their own thing. We needed, and it's tempting, to revert to top-down command and control management, which we know doesn't work with knowledge workers. Instead, we found this way to empower everyone while aligning us all around our success as an enterprise. To do this work well, we need to create a culture of psychological safety. Much of the work that's been seminal here is through Amy Edmondson, professor at Harvard. She describes psychological safety as this belief that no one will be punished or humiliated for speaking up with a great idea, with a concern, or because of a mistake. Now, I may have had a very unique experience in medical school and residency because I never once experienced humiliation because I didn't know something on rounds. Anybody else have that experience? I didn't think so. We come from a culture that's based in this. Somehow back in the old days, the thought was if we weren't terrified that we didn't know everything, we were somehow going to hurt our patients. And we know it's impossible to know everything, but we still are recovering from this culture of intimidation, simply to think that we as professionals who dedicated our lives to this needed to be intimidated in order to learn well. There's also been great people in other industries who have set wonderful examples. One is Paul O'Neill. I don't know if you've heard of him before. For a few years, he was Secretary of State under George W. Bush. He actually left that role voluntarily because he didn't agree with some of what Bush was doing. But he was also the CEO of Alcoa, the largest aluminum manufacturer in the world. And when he became CEO, he went to the first shareholder meeting and announced his strategic priority in order for Alcoa to be the most successful was to focus solely on worker safety. The shareholders, kind of in a room like this, were up in arms. Many of them got up and walked out, getting ready to sell their Alcoa stock because they thought, this is going to tank the stock. If we put all our effort into the safety of the workers, there's no way our shares are going to increase in value. During his tenure, the shares increased by 8 times because he in fact, what he did was he gave this was pre-cell phones, he gave every single worker his home phone number and said, you call me if you feel you're unsafe. And somebody did actually call him, and he called that manager, and they got that fixed, and that changed the culture of the company. So this is And he has 3 questions he likes to ask to see if we've got psychological safety and a good culture. Am I treated every day with respect? Am I given the resources I need? And am I recognized for the great work that I do? Another person who's been a great leader in industry around this is a gentleman who actually spoke at the ACPH back in 2019, Bob Chapman. If you were there, you may recognize his picture. He runs a company called Barry Wehmiller. They make heavy equipment like bottle washers for Budweiser, but in his organization, he has created this level of connection amongst every single person in the organization. When I saw him present, I was sent, when I first joined a consulting firm, to the Association for Manufacturing Excellence, people who make bottle washers for Budweiser, garage doors and widgets, and I thought, what am I going to learn from these type of people? I'm in healthcare, we have a noble mission. There's no way I can learn something from these people. And Bob presented himself and 5 other CEOs who took this approach of caring deeply for each other as though you were close friends and family. Bob's company now, with 80 plants in 20 countries around the world, has a better return on equity than Warren Buffett and Berkshire Hathaway. And his company, Barry Wehmiller, is not experiencing the great resignation. In fact, they're experiencing the great onslaught of people trying to get in and join his company. His book, Everybody Matters, is a classic. I highly recommend it if you're in a leadership role like this. This means that, so that's how we get empowered and create safety for empowerment. How do we align? This is the 3rd portion of audience participation today. And I'm going to ask a question. Usually when I ask this question, somebody kind of thinks they know the answer, and because they think, I'm not sure if this is a psychologically safe culture and environment here, I'm going to just whisper it in case I'm wrong. But everybody's always right. And so I'm going to ask us to have a culture of psychological safety here in this room. And when I ask this question, I want you to shout out your answer, because you know what? You're going to have the right answer. Who is the most important person in your healthcare organization? It's the... Wow. I am blown away. Let's try that one more time. Who is the most important person in your healthcare organization? It's the patient. Thank you. Without a patient, we have no reason to have our jobs. We have no reason for our health systems to exist. What's the most important thing that happens to that most important person? It's a healing interaction that takes place between everyone on the front lines and that patient. Doctors, nurses, technicians, therapists, receptionists, transport people, EVS people. Every time we interact with a patient, we have a chance to make it a healing interaction, to reduce anxiety and worry, to relieve pain and suffering, to educate people to be healthier, to do a definitive procedure. Now, as a family physician for 25 years, I had 100,000 healing interactions in my career. As I moved up the leadership chain, down this inverted org chart to that person at the bottom, as CEO, I stopped seeing patients. I was no longer doing the most important thing for the most important person in my organization. My job was to make sure those people on the front lines had what they needed. In fact, my job was to make sure the people between me and the front lines knew what their role was to make sure those people had what they needed, and to train everyone as dyad or triad paired leadership teams, and make sure our support services knew that was their job as well. Whether they were in HR, IT, or finance, their job really was to make sure people on the front lines had what they needed to do this most important work for the most important person in the organization. This type of leadership is tough. It can't be delegated. It takes courage and commitment. Because we're setting expectations and driving culture change. It does make a difference. For every 1% improvement in the quality of a leader, there's a 4% reduction in burnout. We have to do this by being seen and heard. That means being out there. We can't do this work and make decisions based solely on sitting in a conference room with a committee looking at spreadsheets and reports. We have to go be where the work is to understand the work. Shadowing clinicians, like when we were in medical school and we shadowed our attending. If we're going to understand the work, particularly if you're no longer doing clinical work, you need to go and see what's really happening. When I stopped seeing patients as a CEO, I followed clinicians, and not only had I experienced my own pain as a family doctor, but I understood the pain of an obstetrician, an ophthalmologist, a pediatrician, you name it. because everybody's pain is a little bit different. And if you're a clinician, and particularly if you don't have any of these leadership roles, you might be thinking, okay, that's great. What about me? You invite leaders to come and shadow you with open arms, not with judgment, not to prove to them how bad your life is. You invite them so that they can see, so you can appreciate that they care about you. And then attend huddles. Don't come to huddles to answer and solve the problems. We come to huddles to educate the people who are in the site to become their own problem solvers. An opportunity to bridge this chasm is a CEO Clinician Council, bringing together the CEO with frontline clinicians, not just for a little social hour, but with intent to address problems. Sometimes, and there's a lot of variations of ways we can do this. We're doing this work with some safety net hospitals in New York City right now. They're finding tremendous value, and in fact, they're bringing in to meetings between the emergency physicians and the C-suite, they're bringing in the safety team, they're bringing in the nursing team, they're bringing in the tech team so that they can hear directly what their challenges are. It's important in these meetings that the leaders take notes, listen, take notes, and follow up. And both parties learn new perspectives about each other. Leadership development is crucial. We don't naturally learn how to lead. Leadership development can be done on site. If it is, then bringing together triad and dyad leadership teams in the training is important. But we can go to outside training, even at conferences like this. And executive coaching, if you're in a leadership position, get a coach. No matter how good you think you are, you'll always be better if you have a coach helping you think through this. You know, the best athletes in the world, like Tom Brady, et cetera, have coaches that work with them on a regular basis. If you want to be good, get a coach. Mergers and acquisitions, we touched briefly on this. These are absolutely vital. We were dealing with the middle of them, but the problem is we come together without aligned mission, vision, and values. There's a process called a compact that can help us to align. It's actually described in great detail in a great book, and The New Compact by Mary Jane Kornacki. She and her husband, Jack Silverson, have coached medical groups on this over the years. And it takes the values that we all aspire to, the actions that we use to achieve those values, and creates a reciprocal agreement that our organization will provide the resources we need to achieve those values. And everyone in the organization gets a say in it before it's codified and deployed. Follow this with a daily management system, based on those daily huddles, but escalating from the first huddle that happens up there in the upper corner between staff and supervisors, and has sequential huddles with the supervisors huddling with managers, directors huddling with C-level leaders, so that information flows up, resources can be addressed. And information flows back from the senior leaders to the front lines, so people understand that. And here, you might be looking at this and saying, oh, that's really a pretty diagram, Paul. But that ain't never going to happen in our organization. So I'd ask you to think back to the start of the pandemic. Did your organization have a command center? Because things were so overwhelming that people on the front lines were desperate for help, and the senior leaders realized, we need to do something. We're going to bring together everyone who affects the care of the patient in any tangential way, make sure that the people on the front lines had what they need just to simply protect themselves and survive. And in fact, what's happened since is these command centers, as the pandemic has waned, they're not meeting as frequently. They may be meeting once a week, maybe once a month. And yet, I would ask you, is there still a crisis? If we don't have enough money to keep the doors open, and our doctors and nurses are burning out, isn't there still a crisis? And the organizations that realize this and address this crisis with the same level they addressed what we just did 2 years ago with the pandemic are the ones that create organizational resilience. This is your best opportunity to be successful and survive. In fact, Darwin said, it doesn't matter how strong you are, how smart you are, how quick you are. It doesn't even matter what your healthcare market share is in your metropolitan area. What matters is your ability to rapidly adapt to change. When we do this work well, then we see what many of us in this room are really here for. A quote from a physician that I've worked with. I don't know how long I could have continued to work as I was. Now I have time for more of a life to exercise, spend time with family. It's made my life more balanced. Now I can see practicing for another 20 or 30 years. wouldn't it be great to have everyone in your healthcare organization be able to say this same thing? So I've got a couple slides to wrap up, but I'd like to stop now and have a discussion. Answer a few questions that you may have, if you're online, feel free to put them in the chat. If you're in the room, there's microphones on either side, and I welcome opportunity to discuss that. While people are coming up, just make a note that you've seen all of our books out there on the tables, on the chairs. My co-author, there's the question. Anyway, on that picture, there was a picture of Diane Shannon, my co-author. She's here, Diane. And we will be signing books during the poster session this afternoon. So if you want to come by and get our signatures on your book, we're really happy to do that. So with that, I see a question here. Involving physicians finding solutions is a great idea. How might we balance this from making them feel further taken advantage of to do more work they're not paid to do in order to improve the institution and environment? Really important question. If this work that we're doing to improve things is of value, as is our patient care, shouldn't we be getting paid for that work as well? And the answer is yes. Sometimes I'll have a CFO ask me about the return on investment for something I'm suggesting they do that we invest money in. Or people are given too little administrative time to do a large administrative role. We ask for more, and we're wondering if there's capacity to do that. And every once in a while, I'll just ask the CFO, well, what's the return on investment on your salary and benefits? How are you helping out? How do you measure that? Because if you're asking us to measure the return on investment of things we're doing, that should really go both ways. This is valuable work. In fact, as I said, it's some of the most valuable work. This takes culture change at a leadership level. One way to get started, quite often people will ask, that's great, thanks, nice talk, but what do I do next week when I go back to my office? And what I say is, the most impactful thing you can do, if you're in a leadership role, go shadow clinicians. If you're a clinician, invite a leader to come and shadow you. You don't have to go to the CEO if you've never met him before, or her before, but you could go to your manager or ask your manager to recommend someone that might be a director for them to come and spend a little time with you and really see what it's like. That connection, that ability to see what's actually happening can be more impactful than almost anything else we do. Any other questions? All right, I've answered everything. There's no questions to be had. So let me just wrap up. If I can get back to the slides. This has been a talk, people are probably sitting here thinking, well, this is a great talk. Good for you. Can it really happen? Will it really work? It actually can. I don't see my slides showing to everybody here. Can we get those up on? There we go. Well, I'm here to tell you that empowerment and alignment does work. Back in 2009, I became the CEO of a 300-physician medical group in Modesto, California. Now, we had trouble recruiting doctors because their spouses would look up Modesto in Wikipedia and see that we were the car theft capital of the United States of America, and wondered if they really wanted to move their families there. So we had to create a great professional experience. But 2009 was the depths of the real estate recession. And most of the country was around 9 or 10% unemployment. In Modesto, it was 18% unemployment. Many of our frontline staff were the sole breadwinners for their families because their husbands had been laid off from their construction jobs because construction shut down completely. But we launched this work at that time. And unbeknownst to us, Consumer Reports and the California Healthcare Performance Information System was tracking tracking performance among 170 medical groups across the state of California. And all of a sudden, one day in 2014, one of my doctors came running in, holding up a copy of Consumer Reports and said, "Hey, we just got rated the best overall among 170 medical groups across the state." And they did this the next year, and we got rated that same way again. And we didn't do this, and this was 2014, 5 years later. We didn't do this on the backs of our physicians. Our physician satisfaction went from P45 to P87. We did this because we reached out, we empowered, we engaged, and we aligned. I was so fortunate to have a team, my leadership team, that understood this work and that were committed to doing it. And if we can do this in Modesto, California, there's no reason anyone in this room can't lead this work as well. Now is the time to make healthcare workplaces healthy places for clinicians to work. We have no choice, but I'm calling on all of you, because you must be this change that we all wish to see. The people in this room, the power in this room, is what will make that difference. So I want to thank you all for your attention, for your patience, and wish you a great conference as we go forward, because coming from here, you'll see everything you need to learn in order to lead this movement further. Thank you so much.
Now we will have a break, and the breakouts will start in different rooms. Please see your agendas. We're going to take a break, and we'll go to breakouts. Please see your agenda for the different topics. Thank you.
Yeah.
What coaching program would you suggest for someone like myself who wants to become physicians and maybe executives?
Trying to